Good afternoon. Today I would like to introduce you the next pharmacology lecture, drugs acting on autonomic nervous system, specifically adrenergic drugs. Lecture plan: general considerations, adrenergic drugs and anti-adrenergic drugs. Let's start from general considerations. As you remember, nervous system is classified into central nervous system and peripheral nervous system. Central nervous system is subclassified into brain and spinal cord. Spinal cord connects brain and peripheral nervous system. Peripheral nervous system carries messages to and from the CNS, is subdivided into somatic nervous system, which controls voluntary muscles and transmits sensory information to the CNS, and autonomic nervous system, which controls involuntary body functions. And autonomic nervous system itself is subdivided into sympathetic nervous system, which arouses body to expend energy, and parasympathetic nervous system, which calms body to conserve and maintain energy. Today we will talk about sympathetic nervous system. And also I would like to remind you the effects of stimulation of sympathetic and parasympathetic divisions. As we are talking today about sympathetic division, let's take some organ, for example, heart. In cases of stimulation of sympathetic division, increased heart rate, increased force of contraction. Blood vessels, constriction. Lungs, dilation of bronchioles and inhibition of mucus secretion. Digestive tract, decreased motility movement, contraction of sphincters, inhibition of digestive secretions. Urinary bladder, relaxation. Eye, dilation of pupil, adjustment of eye for far vision. Liver, glycogen stores, glycogenolysis, glucose releases. And adipose cells, fat stores, lipolysis, fatty acids released. Next slide is catecholamines. Catecholamines are the neurotransmitters which are responsible for the transmission in sympathetic nervous system. Catecholamine is a monoamine neurotransmitter, an organic compound that has a catechol and a side chain amine. Below you can see the picture of catechol. Catecholamines are derived from the amino acid tyrosine, which is derived from dietary sources, as well as synthesis from phenylalanine. Catecholamines are water-soluble and are 50% bound to plasma proteins in circulation. Included among catecholamines are epinephrine or adrenaline, norepinephrine or noradrenaline, and dopamine. Release of the hormones epinephrine and norepinephrine from the adrenal medulla of the adrenal glands is part of the fight or flight response. Tyrosine is created from phenylalanine by hydroxylation by the enzyme phenylalanine hydroxylase. Tyrosine is also ingested directly from dietary proteins. Catecholamine secreting cells use several reactions to convert tyrosine serially to L-DOPA and then to dopamine. Depending on the cell type, dopamine may be further converted to norepinephrine or even further converted to epinephrine. Catecholamines are absorbed from intestine but rapidly degraded by monoamino oxidase and catechol orthomethyltransferase, which are present in intestinal wall and liver. They are thus orally inactive. And on this slide you can see the schematic representation of synthesis of catecholamines, which I mentioned before. Tyrosine hydroxylase is a specific enzyme, others are rather non-specific. On this slide you can see the pathways of metabolism of catecholamines. Part of the noradrenaline leaking out from vesicles into cytoplasm, as well as that taken up by axonal transport, is first attacked by monoamino oxidase, while that which diffuses into circulation is first acted upon by catechol orthomethyltransferase in liver and other tissues. In both cases, the alternative enzyme can subsequently act to produce vanillyl mandelic acid, VMA. Other intermediate steps enzymes involved are aldehyde reductase, AR, aldehyde dehydrogenase, AD, and alcohol dehydrogenase, ADH. The major metabolites excreted in urine are vanillyl mandelic acid, and 3-methoxy-4-hydroxyphenylglycol, a reduced product, along with some metanephrine, normetanephrine, and 3,4-dihydroxymandelic acid. These metabolites are mostly conjugated with glucuronic acid or sulfate before excretion in urine. And also about uptake of catecholamines. Axonal uptake, norepinephrine transporter, vesicular uptake, vesicular monoamine transporter, extraneural uptake, extraneural amine transporter, or organic cation transporter. And on this slide you can see modification of adrenergic transmission by drugs. For example, reserpine, guanetidine, tyramine, cocaine, monoamino oxidase inhibitors, and others. And on this slide you can see dose response curves of catecholamines on isolated aortic strip and isolated bronchial smooth muscle. Agents which you can see: adrenaline, noradrenaline, and isoprenaline, and in here isoprenaline, adrenaline, and noradrenaline. This picture illustrates two distinct RAN orders of potencies, respectively for alpha and beta adrenergic receptors. Adrenergic receptors are membrane-bound G-protein coupled receptors which increase or decrease the intracellular production of second messengers such as CIMP, 3,5-cyclic adenosine monophosphate, or IP3-DAG, inositol triphosphate diacylglycerol. In some cases, the activation of G proteins itself operates potassium or calcium channels or increases prostaglandin production. G proteins: GS, adenylyl cyclase activation, calcium channel opening; GI, adenylyl cyclase inhibition, potassium channel opening; GO, calcium channel inhibition; GQ, phospholipase C activation. Classification of adrenergic receptors. Adrenergic receptors are divided into alpha and beta receptors. Alpha receptors are subdivided into alpha 1 and alpha 2. Alpha 1 are subdivided into alpha 1A, alpha 1B, and alpha 1D. Alpha 2 adrenoreceptors are subdivided into alpha 2A, alpha 2B, and alpha 2C. Beta receptors are subdivided into beta 1, beta 2, and beta 3. Adrenergic receptors differentiation. Alquist in 1948, on the basis of two distinct rank orders of potencies of adrenergic agonists, classified adrenergic receptors into two types, alpha and beta. This classification was confirmed later by the discovery of selective alpha and beta adrenergic agonists. On the basis of relative organ specificity of selective agonists and antagonists, beta receptors were further subdivided into beta 1 and beta 2 subtypes. Later, beta 3 receptors were described, which are more sensitive to noradrenaline than to adrenaline and have very low affinity for the standard beta blockers. In 1970s, alpha receptors were differentiated into alpha 1 and alpha 2. However, the classification is based on pharmacological criteria, selective agonists and antagonists, and not on anatomical location. Molecular cloning has further identified 3 subtypes of alpha 1 and 3 subtypes of alpha 2 receptors. Differences between alpha and beta receptors. In here you can see rank order of potency of agonists, antagonist, coupling protein, and effector pathway. Though inherently noradrenaline is equipotent to adrenaline on alpha receptors in test systems, it appears less potent due to faster reuptake. Isoprenaline or isoproterenol, or as you can see in here, ISO, is a medication used for the treatment of bradycardia, heart block, and rarely for asthma. It is a non-selective beta adrenoreceptor agonist that is the isopropylamine analog of epinephrine. And on this slide you can see differences between alpha 1 and alpha 2 receptors. For example, location: alpha 1 post-junctional on effector organ, alpha 2 pre-junctional on nerve ending, alpha 2A also post-junctional in brain, pancreatic beta cells, and extra-junctional in certain blood vessels, platelets. Functions observed: genitourinary smooth muscles contraction, vasoconstriction, gland secretion, gut relaxation, liver glycogenolysis, heart arrhythmia. Alpha 2, inhibition of transmitter release, vasoconstriction, decreased central sympathetic flow, decreased insulin release, platelet aggregation. Also, which are selective agonists, selective antagonists, coupling protein, and effector pathway. And in here you can see differences between beta 1, beta 2, and beta 3 receptors. Location: beta 1 in heart and juxtaglomerular cells in kidneys. Beta 2 bronchi, uterus, blood vessels, urinary tract, eyes. Beta 3 adipose tissue. Functions: positive inotropic and chronotropic. Beta 2 bronchodilation. Beta 3 lipolysis. Also you can see agonists, antagonists, and action on norepinephrine. In here you can see comparative effects of IV infusion of adrenaline, noradrenaline, and isoprenaline. For example, on heart rate, cardiac output, blood pressure, blood flow, bronchial muscle, intestinal muscle, and blood sugar. And here you can see summarized distribution of adrenoreceptor subtypes. For example, alpha 1, tissue, most vascular smooth muscles, action, contraction. Pupillary dilator muscle, contraction. Pilomotor smooth muscle, erects hair. Prostate, contraction. Heart, increases force of contraction. Alpha 2, postsynaptic CNS adrenoreceptors, probably multiple. Platelets, aggregation. Adrenergic and cholinergic nerve terminals, inhibition of transmitter release. Some vascular smooth muscle, contraction. Fat cells, inhibition of lipolysis. Beta 1, heart juxtaglomerular cells, increases force and rate of contraction, increases renin release. Beta 2, respiratory, uterine, and vascular smooth muscle, promotes smooth muscle relaxation. Skeletal muscle, promotes potassium uptake. Human liver, increased release of glucagon, activates glycogenolysis. Fat cells, activates lipolysis. The action of particular sympathomimetic amine depends on its relative activity at different types of adrenergic receptors. Adrenaline, alpha 1 plus alpha 2, beta 1 plus beta 2, and weak beta 3 action. Noradrenaline, alpha 1 plus alpha 2 plus beta 1 plus beta 3, but no beta 2 action. Isoprenaline, beta 1 plus beta 2 plus beta 3, but no alpha action. And on this slide you can see adrenergic response mediated through alpha and beta receptors. For example, alpha actions, constriction of arterioles and veins, rise in BP, alpha 1 plus alpha 2. Beta actions, dilatation of arterioles and veins, fall in BP, beta 2. Heart, little action, arrhythmia at high dose, alpha 1. Beta actions, cardiac stimulation, beta 1, increased rate, force, and conduction velocity. Bronchioles, for alpha actions, none. Beta actions, bronchodilation for beta 2. Eyes, contraction of radial muscle of iris, mydriasis, for alpha 1, decreased aqueous secretion. Beta actions, no effect on iris, slight relaxation of ciliary muscle, enhanced aqueous secretion. Intestines, alpha actions, intestinal relaxation, contraction of sphincters. Beta actions, intestinal relaxation, beta 2, and others. The next part of our lecture is adrenergic drugs. Let's start from sympathomimetics. They are classified into direct sympathomimetics, mechanism of action, directly act as an agonist on alpha and or beta adrenoreceptors. Examples: adrenaline, noradrenaline, isoprenaline, phenylephrine, methoxamine, xylometazoline, salbutamol, etc. Indirect sympathomimetics, mechanism of action, act on adrenergic neuron to release noradrenaline, which then acts on adrenoreceptors, for example, tyramine and amphetamine. And mixed action sympathomimetics, mechanism of action, they act directly as well as indirectly. Examples: ephedrine, dopamine, and methamphetamine. Administration and drugs. Adrenaline for systemic action 0.2 till 0.5 mg subcutaneously or intramuscular. Action lasts from half an hour to 2 hours. Drug form, solution 1 mg milliliter or 0.1% 1 milliliter ampoule. As local vasoconstrictor, correlation 1 to 200,000 or 1 to 100,000 added to lidocaine. Noradrenaline, 2-4 micrograms minute IV infusions. Local tissue necrosis occur if the solution extravasates, never mix with sodium hydrocarbonate in same bottle because of rapid oxidation. Action starts declining within 5 minutes of discontinuing infusion. It is rarely used now as pressor agent. Drug form, solution 2 mg each milliliter or 0.2% 1 milliliter ampoule. Isoprenaline or isoproterenol 20 mg sublingual IM and 5-10 micrograms minute IV infusions. Action lasts 1-3 hours. It is occasionally used to maintain idioventricular rate till pacemaker is implanted. For bronchial asthma, it has been superseded by selective beta-2 agonists. Action of adrenergic drugs. Heart increases heart rate. Blood vessels, alpha vasoconstriction, beta-2 vasodilation. Blood pressure, effect depends on the amine and its dose. Respiration, beta-2 bronchodilation. Eye, mydriasis due to alpha-1 constriction of radial iris muscles. Gastrointestinal tract, peristaltic is reduced. Bladder, detrusor relaxed by beta and trigon constricted by alpha. Uterus, relaxes in case of pregnancy. Splenic capsule, contracts by stimulation of alpha receptors. Skeletal muscle, acetylcholine release, but adrenaline augments contraction. CNS, poor penetration in brain, but alpha-2 agonists decrease sympathetic outflow, leading to bradycardias and decreasing blood pressure. Metabolic action causes glycogenolysis, hyperglycemia, and lipolysis, rise in plasma-free fatty acids. Next one is therapeutic classification of adrenergic drugs. Pressor agents, noradrenaline, ephedrine, dopamine, phenylephrine. Cardiac stimulants, adrenaline, dobutamine, isoprenaline. Bronchodilators, salbutamol, terbutaline, salmeterol, formoterol, bambuterol. Nasal decongestants, phenylephrine, xylometazoline, oxymetazoline, nafazoline, pseudoephedrine, phenylpropanolamine. CNS stimulants, amphetamine, dexamphetamine, methamphetamine. Anorectics, fenfluramine, dexfenfluramine, sibutramine. Uterine relaxants and vasodilators, ritodrine, isoxsuprine, salbutamol, terbutaline. First one is pressor agents. Noradrenaline, natural neurotransmitter. Ephedrine, alkaloid obtained from Ephedra vulgaris, indirectly acts as well as on alpha and beta receptors. Dopamine, D1 and D2 receptors agonist, as well as alpha and beta 1, but not beta 2 agonist. Phenylephrine, selective alpha 1 agonist, has negligible beta action, because of this little cardiac action. Second, cardiac stimulants. Adrenaline, natural neurotransmitter. Dobutamine, derived from dopamine, but not D1 and D2 receptors agonist, acts on both alpha and beta adrenergic receptors. From 1 to 8 micrograms kilogram each minute, IV infusion. Is increased force of cardiac contraction and output without significant change in heart rate, peripheral resistance, and blood pressure. As such, it is considered as a selective beta-1 agonist. This is why it is used as an inotropic agent in pump failure accompanying myocardial infarction, cardiac surgery, and for short-term management of severe congestive heart failure. It is less arrhythmogenic than adrenaline. The third is bronchodilators. Salbutamol, a highly selective beta-2 adrenergic agonist, produces bronchodilation within 5 minutes and the action lasts for 2-4 hours. Muscle tremors are the dose-related side effect. Palpitation, restlessness, nervousness, throat irritation, and ankle edema can also occur. Hypokalemia is a possible complication. Salbutamol undergoes presystemic metabolism in the gut wall. Oral bioavailability is 50%. Orally acts for 6 hours, administered to patients who cannot correctly use inhalers. 2 4 mg tablets, 100 micrograms metered dose inhaler. Terbutaline is similar to salbutamol, 5 mg tablets, 250 micrograms dose inhaler. Bambuterol. Biscarbamate ester prodrug of terbutaline is slowly hydrolyzed in plasma by pseudocholinesterase to release the active drug over 24 hours. Salmeterol, first long-acting selective beta-2 adrenergic agonist with a slow onset of action, by inhaler twice a day. It is more selective than salbutamol. Formoterol, long-acting selective beta-2 agonist, which acts for 12 hours. Fourth is nasal decongestants. Phenylephrine is a selective alpha-1 agonist, has negligible beta action, rises BP by causing vasoconstriction. Because of this cardiac action, reflex bradycardia is prominent. Topically, it is used as a nasal decongestant and in the eye for production of mydriasis when cycloplegia is not required. It tends to reduce intraocular tension by constricting ciliary body blood vessels. The other representatives are xylometazoline, oxymetazoline, and nafazoline. Pseudoephedrine, a stereoisomer of ephedrine, causes vasoconstriction, especially in mucosa and skin, but has fewer CNS and cardiac effect and is poor bronchodilator, little beta-2 agonist. 30-60 mg 3 times a day. Phenylpropanolamine is a sympathomimetic agent which is used as a decongestant and appetite suppressant. It was commonly used in prescription and over-the-counter cough and cold preparations. In veterinary medicine, it is used to control urinary incontinence in dogs. The fifth, CNS stimulants. Amphetamine. Synthetic compounds having a pharmacological profile similar to ephedrine. Orally active with a relatively long duration, 4-6 hours. The central action largely mediated by release of noradrenaline from adrenergic neurons in the brain by exchange diffusion and reverse transport, involving NET, DAT, and VMAT2. They exert potent CNS stimulant and weaker peripheral cardiovascular action. Maximal selectivity is exhibited by dextroamphetamine and methamphetamine, which in usual doses produce few peripheral effects, from 5 to 15 mg oral. 6. Anorectics. Fenfluramine, formerly sold under the brand name Pondemine, is an appetite suppressant which was used to treat obesity and is now no longer marketed. It was used both on its own and in combination with phentermine as part of the anti-obesity medication fen-phen. Next one, dexfenfluramine, marketed as dexfenfluramine hydrochloride under the name Redux, is a serotonergic anorectic drug. It reduces appetite by increasing the amount of extracellular serotonin in the brain. It is the D-enantiomer of fenfluramine and is structurally similar to amphetamine but lacks any stimulating effects. Sibutramine, formerly sold under the brand name Meridia among others, is an appetite suppressant which has been discontinued in many countries. Until 2010, it was widely marketed and prescribed as an adjunct in treatment of obesity along with diet and exercise. It has been associated with increased cardiovascular events and strokes and has been withdrawn from the market in several countries and regions including Australia, Canada, China, European Union, Hong Kong, India, Mexico, New Zealand, Philippines, Thailand, United Kingdom, and the United States. However, the drug remains available in some other countries. Seventh, uterine relaxants and vasodilators. Ritodrine, trade name Utopar, is a tocolytic drug used to stop premature labor. This drug has been removed from the US market according to the FDA Orange Book. It was available in oral tablets or as an injection and was typically used as the hydrochloride solid ritodrine hydrochloride. Isoxsuprine, used as isoxsuprine hydrochloride, is a drug used as a vasodilator in humans under the trade name Duva-Dilan and equines. Isoxsuprine is a beta-2 adrenergic receptor agonist that causes direct relaxation of uterine and vascular smooth muscles via beta-2 receptors. Others are salbutamol and terbutaline, about which I mentioned before. Adverse effects and contraindications. Transient restlessness, headache, palpitation, anxiety, tremor, and pallor may occur after subcutaneous intramuscular injection of adrenaline. Marked rise of blood pressure leading to cerebral hemorrhage, ventricular tachycardia fibrillation, angina, myocardial infarction are the hazards of large dose or inadvertent IV injection of adrenaline. Adrenaline is contraindicated in hypertensive, hyperthyroid, and angina patients. Adrenaline should not be given during anesthesia with halotan because of risk of arrhythmias, and to patients which are receiving beta blockers. Marked rise in BP can occur due to unopposed alpha action. And the third part of our lecture is anti-adrenergic drugs. The first group is alpha-adrenergic blockers. Mechanism of action. These drugs inhibit adrenergic responses mediated through alpha-adrenergic receptors without affecting those mediated through beta receptors. Classification. Non-equilibrium type, for example, beta-haloalkylamines, phenoxybenzamine. Equilibrium type, competitive, which is subdivided into non-selective, alpha-1 selective, and alpha-2 selective. From non-selective, for example, ergot alkaloids, ergotamine, ergotoxin. Hydrogenated ergot alkaloids, for example, dihydroergotamine, dihydroergotoxin. Imidazolines, phentolamine, miscellaneous chlorpromazine. Alpha-1 selective, prazosine, terazosine, doxazosine, alfuzosine, tamsulosine. Alpha-2 selective, yohimbine. Now let's stop on each of them in details. First, non-equilibrium type, irreversible alpha blockade. Phenoxybenzamine, 20-60 mg in a day orally. Alpha-adrenergic receptors blockade is of non-equilibrium irreversible type and develops gradually even after IV injection and lasts for 3-4 days till fresh receptors are synthesized. Partial blockade of 5-HT, histaminergic and cholinergic receptors, but not beta-adrenergic receptors, can be demonstrated at higher doses. The fall of BP is mainly postural because of venodilation is more prominent than arteriolar dilation. The next one are non-selective equilibrium type or competitive alpha-adrenergic blockers. On the example of phentolamine, rapidly acting alpha blocker with short duration of action in minutes equally blocks alpha-1 and alpha-2 receptors. Noradrenaline release is increased and venodilation predominate over arteriolar dilatation. It is used as a quick and short-acting alpha blocker for diagnosis and intraoperative management of pheochromocytoma and for control of hypertension due to clonidine withdrawal, cheese reactions, etc. 5 mg IV repeated as required. Chlorpromazine and some other neuroleptics have significant alpha-adrenergic blocking activity, cause fall in BP, nasal stuffiness, and inhibition of ejaculation as side effects. The next one are alpha-1 selective equilibrium type or competitive alpha-adrenergic blockers, for example, prazosine. First, highly selective alpha-1 adrenergic receptors antagonist. In comparison between alpha-1 and alpha-2 receptors, the selectivity ratio is 1000 to 1. All subtypes of alpha receptors are blocked equally. It blocks sympathetically mediated vasoconstriction and produces fall in blood pressure, which is attended by only mild tachycardia. Terazosin is chemically and pharmacologically similar to prazosin. Difference are higher bioavailability, around 90%, and longer plasma half-life, around 12 hours. Doxazosine, long-acting, half-life approximately 18 hours, congener of prazosin. Alfuzosine, short-acting, half-life approximately 3-5 hours, congener of prazosin. Tamsulosin, relatively uroselective alpha-1A, alpha-1D blocker, has been found as effective as terazosin in improving BHP symptoms. However, it lacks the prostatic apoptosis promoting property of terazosin and doxazosine. The next one is alpha-2 selective equilibrium type or competitive alpha-adrenergic blocker. As an example, yohimbine, an alkaloid from the West African plant Corinanthe, it is a relatively selective alpha-2 blocker with short duration of action. Also blocks 5-HT receptors. Heart rate and blood pressure are generally elevated due to increased central sympathetic outflow as well as enhanced peripheral noradrenaline release. Other CNS effects include excitation, tremor, antidiuretic hormone release, nausea, and vomiting. It may cause congestion in genitals and has been considered to be an aphrodisiac. The effect is only psychological, but can overcome psychogenic impotence in some patients. There are no valid clinical indications for use of yohimbine, in some cases, treatment of erectile dysfunction. General effects of alpha-adrenergic blockers. Blockade of vasoconstrictor alpha-1, also alpha-2, receptors reduce peripheral resistance and causes pooling of blood in capacitance vessels. Venous return and cardiac output are reduced. Fall in blood pressure. Postural reflex is interfered with marked hypotension occur on standing, dizziness and syncope. Second, reflex tachycardia. Third, nasal stuffiness and meiosis. Also, intestinal motility is increased due to partial inhibition of relaxant sympathetic influences. Loose motion may occur. Hypotension can lead to reduction of renal blood flow. More complete reabsorption of sodium and water occurs. Sodium retention and expansion of blood volume. Tone of smooth muscle in bladder, trigon, sphincter, and prostate is reduced, mostly alpha-1A subtype. Contraction of vas deferens and related organs, which result in ejaculation, are coordinated through alpha receptors. Alpha blockers can inhibit ejaculation. This may manifest as impotence. The next pharmacological group is beta-adrenergic blockers. Classification: non-selective, beta-1 and beta-2. They are subclassified into those which are without intrinsic sympathomimetic activity, for example, propranolol, sotalol, timolol. Those which are with intrinsic sympathomimetic activity, for example, pindolol, and with additional alpha-blocking activity, for example, labetalol and carvedilol. And the second group is cardioselective, beta-1. Metoprolol, atenolol, acebutolol, bisoprolol, esmolol, betaxolol, celoprolol, nebivolol. Also, beta blockers can be classified into 3 generations. First generation non-selective, nadolol, oxprenolol, penbotalol, pindolol, and others. Second generation beta-1 selective, acebutolol, atenolol, bisoprolol, esmolol, metoprolol, and third generation vasodilatory, which are subdivided into non-selective, for example, carteolol, carvedilol, labetalol, and beta-1 selective, betaxolol, nebivolol. These, carvedilol and labetalol, once again have got additional alpha-blocking activity. Mechanism of action of beta-adrenergic blockers. These drugs inhibit adrenergic responses mediated through beta receptors. The dichloroderivative of isoprenaline was the first compound found in 1958 to block adrenergic receptors, which could not be blocked then by available adrenergic antagonists. However, it was not suitable for clinical use, and propranolol, introduced in 1963, was a therapeutic breakthrough. All beta blockers are competitive antagonists. Propranolol blocks beta-1 and beta-2 receptors, but has a weak activity on beta-3 subtype. It is also an inverse agonist, reduce resting heart rate as well. Some beta blockers like metoprolol atenolol preferentially block beta-1 receptors, while few others have additional alpha-1 receptor blocking and or vasodilator properties. And on this slide you can see comparative properties of some beta-adrenergic blocking drugs. Non-selective, cardioselective alpha plus beta blockers, their potency, partial agonistic action, membrane stabilizing action, lipid solubility, daily dose, oral bioavailability, first pass metabolism, Mayo route of elimination, plasma half-life. The next pharmacological group is alpha plus beta adrenoblockers. The representatives are labetalol and carvedilol. For example, labetalol, the beta-blocking potency is about 1/3 that of propranolol, while alpha-blocking potency is about 1/10 of pentolamine. Labetalol is 5 times more potent in blocking beta receptors than alpha receptors. Low dose resemble effects of propranolol alone, high dose like a combination of propranolol and prazosin. Fall in blood pressure is due to alpha-1 and beta-1 blockade, as well as beta-2 agonism. Heart rate is unchanged or slightly decreased. In contrast to propranolol, limb blood flow increases with labetalol. Also inhibit noradrenaline uptake by adrenergic nerve endings. Labetalol is orally effective but undergoes considerable first-pass metabolism. Uses: hypertension, pheochromocytoma, and clonidine withdrawal. Side effects: postural hypotension, failure of ejaculation, rashes and liver damage, and other side effects of alpha and beta blockers. Carvedilol produces vasodilation due to alpha-1 blockade as well as calcium channel blockade, and also has antioxidant property. It has been used in hypertension and is the beta blocker especially employed as cardioprotective in chronic heart failure. Oral bioavailability of carvedilol is 30%. It is primarily metabolized and has time of half elimination of 6 to 8 hours. And the last pharmacological group for today is sympatholytics. The representatives are reserpine, raunatin, octadine. Mechanism of action: inhibition of the effects of stimulation of sympathetic nerves, but they do not prevent the action of exogenous adrenaline and norepinephrine. The most important thing in sympatholytic action is their effect on the cardiovascular system, namely the antihypertensive effect, for which they are used in the clinic for the treatment of hypertension. Indications for use: the main indication of reserpine is arterial hypertension. Reserpine is also used for nervous and psychiatric disorders caused by high blood pressure. Raunatin is prescribed primarily as an antihypertensive agent in various forms of arterial hypertension, rarely with vegetative vascular dystonia for hypertension type. Side effects: nasal congestion, sweating, general weakness, dizziness, dysfunction of the digestive canal. Side effects disappear after reducing the dose of the drug or stopping its administration. And as the last part of our lecture, I would like to discuss with you some examples of MCQs. A 63-year-old man with collapse symptoms was delivered to the emergency hospital. A doctor chose noradrenaline in order to prevent hypotension. What is the action mechanism of this medication? In here specifically, you must remember the mechanism of action of noradrenaline, and of course the mechanism of action will be activation of alpha-1 adrenal receptors. In this MCQ, you will meet with anapreline. Please remember that anapreline, it is the trade name of propranolol. Anapreline therapy caused positive effect in the dynamic of the disease of a 44-year-old woman suffering from stenocardia. Stenocardia, it is the same as angina pectoris. What is the main mechanism of the effect of this medicine? As this drug is beta blocker, of course the answer will be blockade of adrenal receptors and decrease myocardial requirements to the oxygen. An ophthalmologist used 1% mezatone solution for the diagnostic purpose, pupil dilation for eye ground examination. What is the cause of mydriasis induced by the drug? Of course, this drug is alpha-adrenal receptors agonist, so the answer will be activation of alpha-1 adrenal receptors. A patient with myocardial infarction has acute heart failure. Among the drugs that increase the force of heart contractions, the least dangerous in this case will be, of course, the answer is dobutamine. As you remember, it is more selective to beta-1 receptors, so this will be the correct answer. Thank you for the attention.